I had never been confronted with a situation where you were given no belief back from someone, where I actually remember saying to my husband, I feel like I've been dragged into a court with the charge of murder and then told I can't give my defence, and they've found me guilty with no discussion.
Hello and welcome to today's episode of Endo Untangled. My name is Dr Marie-Claire and I'm joined by my co-host Cherie Noble. And today we are talking about POTS. We've called our episode Standing Up to POTS, Untangling Fatigue, Dizziness and Pelvic Pain. We have a special guest with us in the studio today, Dr Marie-Claire Seeley. So let's give you a brief introduction. Dr Marie-Claire Seeley is a clinician researcher and CEO of the Australian POTS Foundation. She completed her PhD at the University of Adelaide, where her work identified a high prevalence of autonomic dysfunction in long COVID. She established Australia's only POTS registry and multidisciplinary service and led successful advocacy for a unique ICD code for POTS in Australia. Marie-Claire combines research, clinical practice, lived experience to drive policy reform and improve access to care. Her leadership has shaped national guidelines and submissions to government, highlighting sex-based disparities and long diagnostic delays in autonomic disorders. She is a postdoctoral research fellow at the University of Adelaide, co-leads international collaborations and has convened major conferences and education initiatives. Marie-Claire, welcome to the show.
Thank you. It's very exciting to be here.
Right. So
we're so excited to have you.
Yeah, excited.
As I mentioned, this episode is very close to my heart, with also some lived experience with my family with this.
Yes.
So I'm really looking forward to this chat. Thank you,
and
Marie-Claire.
I hope that we'll be able to make some space to hear some really important lived experience stories today. Before we start picking the brains of Marie-Claire, I just thought it would be important for us to discuss, why are we talking about POTS? What is POTS? Why are we talking about POTS when we're meant to be talking about endometriosis? Isn't that something to do with endometrial tissue living somewhere where it's not? What I have found as a GP who has now looked after hundreds of women and AFAB folk with complex pelvic pain and endometriosis is that they often feel like they're coming in to talk to me about endometriosis, but what they're coming in to talk to me about is pelvic pain, endometriosis, bowel issues, pelvic floor dysfunction, dysautonomia, which we'll talk about in a minute,
fatigue,
hypermobility,
pain,
gastrointestinal issues, headaches,
nausea.
So many things. And one of the things that I've realised the more I've worked in this space is that there is often a almost predictable overlap of other conditions that are going on. And it's almost different manifestations of an underlying sort of significant stressor or set of stressors on the body that are causing people to have a lot of symptoms and a lot of issues that come in the door to see me. And one of the biggest components to the symptoms that people come in to see me about with their endo is likely due to a condition called POTS or some of the friends that come along with it. So, for those who aren't familiar, POTS stands for Postural Orthostatic Tachycardia Syndrome. When I was in medical school and even as a GP trainee registrar, don't think it came across my desk at all. In fact, the first time I'd heard of POTS is when a patient came in and told me she had it. This was probably 10 years ago, and had to look it up at that point. POTS is a condition which affects all parts of somebody's body, but what it does is there's a defective way of the blood pumping around the body, so that where the system should naturally be able to adapt between lying and sitting and standing and moving and keep blood pressure and pulse at a stable rate, for a number of reasons, including probably some difficulties with someone's automatic nervous system, that doesn't happen as it should, and someone's body system needs to work a lot harder to do what most of the rest of us take for granted. And it seems to come along in a lot of invisible illness that we see, and probably prior to Marie-Claire's work and others like her, it was completely invisible and as we've discussed, often put down as completely psychological or psychiatric, and we know that that is not the case. So Thank you so much for your time in joining us.
Well
I know how
done.
busy you are.
That was a lot. How, Marie-Claire,
I'm just thinking we're going to recruit Alicia.
How do you reckon she did with that?
I think that was a great summary of it, and a great summary succinctly helping the general public to understand it. And it's a very complex disorder, so I think you did very well.
Thank you, Marie-Claire. Cherie, before I start with my questions for Marie-Claire, did you have anything to add or anything personal that you wanted to add about that particular snapshot of what POTS might be like?
Look, again, great succinct description there, which I think really covers it, and that link with endo and bringing in the fact that these complex invisible conditions are sort of clustered in a way that we're seeing with a lot of people affected by a number of things, including my daughter, who's given me permission to share that with this, what we sort of refer to sometimes as a super syndrome. It's not just one thing. It's endo, pelvic pain, a thing called POTS, which we're going to unpack today. And it's so debilitating. Like, I cannot stress how debilitating and disabling these conditions are, and particularly POTS with my daughter. And being a parent of someone who's going through it's even harder, I think, because you feel helpless at times. You don't know how to help this young person who is, managing so many symptoms and, feeling helpless. So again, I think that this is such an important topic that we want to unpack today, and so excited to have Marie-Claire here to unpack this with us.
So, Dr. Marie-Claire, this is clearly an area of passion for you. Before we get started talking more about POTS in detail, can you tell us a little bit about how you came to be such a champion for POTS? And you do mention in your bio, that you have some lived experience of POTS. Are you happy just to talk us a bit through about how you've come to essentially be where you are today?
Sure. I would have to say off the bat, I was a bit of a reluctant champion of the condition. And for those who are listening who don't know me or haven't seen me, I'm slightly older than the average person that does a PhD. So I'm in my later 50s, or at least just over 55. So I actually grew up as a very athletic person. I'm from country West Australia, pretty tough breed out in the farming areas out there. Spent most of my life barefoot, working on the farm, and felt that I was a pretty healthy person, certainly overachieved at most sports that I ever did. And then when I was 22 or so, I went off to save the world. And for those who don't know your history, there was a big collapse of the Iron Curtain in Eastern Europe in the late 80s. And I went over, there was a lot of need for orphanages and different things.
Wow.
So I went over there to work for a couple of years with an international organisation that took young people sojourning around the world at events like that. So I spent a lot of time in Eastern Europe, driving trucks and things in and out, taking food and aid in. Yeah. So during that period, I actually had a few pretty funky conditions that came along. Eastern Europe had been locked away for 80 years. AIDS was rampant there, and there was no, adequate sanitation. So I picked up things like Giardia and so on. So I had lots of gut issues after those incidences. I was also undiagnosed celiac, which we'll talk about later. So I had this history of being somewhat hypermobile, very good athlete, good swimmer, got a bit what we call orthostatically intolerant. And some of your listeners will know the feeling of a hot summer's day if you lay down and sunbake, as we did in the 80s. When you stand up, you might lose your sight for a little while and you might even faint. But it wasn't life-altering. It didn't stop me from doing anything. It was just something all our family had to be aware of. And then I met my now husband there. He was also from Adelaide. I'm from West Australia. He was from Adelaide. And we later married. And we returned after we were married to the Middle East, actually. And on the way to the Middle East, we both picked up a virus in Southeast Asia. My husband, who I now know rarely gets sick, was extremely unwell and ended up in hospital in liver failure. We think it was some kind of tropical virus condition that he had. I got it too, but being a bit sturdier stock and not a male, I didn't have man flu. So I managed to get out of bed, keep doing things. But I had this orthostatic intolerance. It was just getting worse and worse and worse. And my husband got better after being in hospital, and I didn't. I got worse. And at first, I wasn't medically trained. I hadn't gone and done any education at the time. All I knew was when I stood up that losing my eyesight was even worse than it had ever been, but I couldn't catch my breath. I just felt like every last drop of air had gone out of my body. My gut got worse. I lost weight. And it wasn't long before I was finding I just couldn't manage stairs. I couldn't do all these different things. And then one day I actually took my heart rate. I did know how to do that, but I hadn't really thought of doing it. And I realised that I couldn't even count my pulse. It was so high. So eventually we sought some help and we went to the local Turkish hospital where we were living. They, of course, did a echocardiogram. They said, oh, you've got a mitral valve prolapse. That's what's causing it. I didn't actually have back in those times, if you scan everybody's hearts, you'll find a little bit of floppy valve there every so often. And these days they would never call that a mitral valve prolapse, but the assumption was that's what it was.
Although, and we'll get to this later, I wonder whether a degree of floppiness might have actually been part of the picture, if not necessarily the cause of the picture.
Correct. Yeah. It wasn't explaining the intensity of my symptoms, but it certainly was a connection to why I was a person who had developed those symptoms. So I was put on what they would commonly put you on, and that's a beta blocker, which of course just flattened me. So beta blockers, for your audience, if you don't know, they actually lower your blood pressure a bit. And so then I was completely unable to do things.
Wow, that's the last thing you needed at that time.
Yeah. At that time.
It's a medication that's going to cap your heart rate, which is your body's compensation for the lack of the circulating blood volume, which is keeping you upright. And so it probably made your clinicians feel better because your heart rate wasn't as high, but of course you felt worse because you lost your ability to compensate.
And so functionally you become worse. You can do less. You can't think as well because you're not getting blood to your head. You're getting headaches, all the rest of it. But I was, on the outside, I looked normal. And everybody around us at that time was like, oh, but you look well. And there was just this frustrating thing. And I also remember that point in time when I realised my husband had no indication that these episodes were happening. I would have to kind of voice to him, this is happening, because all he saw was me sitting there talking normally. And then, I'd stand up and I'm got my head on the ground, or I've sat back down. So it was hard for him to conceptualise what's going on, and I didn't have the words to give him. I just didn't know. All I could feel was this rush of what I now know as adrenaline of my heart. When we did eventually start kind of tracking, it was going well over 200, just trying to stand up. But I would have days when I was kind of okay, and then I would start thinking to myself, this must be in my head, what is this? We eventually actually moved to Central Asia because more fools us. We thought, we'll eventually go away. And anybody who knows anything about Central Asia, it's right in the middle of a great big landmass. So it's very cold in the winter, very hot in the summer. And we moved in the middle of a summer and it was up to 50 degrees in the middle of summer.
So where are we talking Central Asia?
So this was Uzbekistan.
Wow.
Yeah.
And at this point you're living with your boyfriend, partner, husband, in your mid-20s?
Yes, exactly mid-20s. I was 25.
Yeah, no family support around you in a foreign country.
Correct.
Foreign medical system.
No internet back then. In fact, the first time we ever heard of email was when we were in that country, and we actually were some of the first adopters of it. But we're talking very early in the 90s. So there was no access to... You couldn't Google anything. You couldn't look up and figure out what are these symptoms. There was a book actually called Where There Is No Doctor, which, we would carry with us to try and figure out what was wrong with us. Yeah. But we just didn't have access to anything. And I, of course, did not do very well. And then we eventually heard that, so if you don't know anything about Uzbekistan, it was part of the old USSR. So the Russians, when the USSR kind of broke up, they just evacuated those countries and left these countries to themselves. So everything collapsed in terms of structure. So there was no currency in the country when we were there. There was no medical system. There was no shops. There was no anything. So we didn't have access to healthcare, but we heard that a young Australian doctor from Adelaide actually was coming out to do some clinics to help people that were working out in that area.
Wow.
Expats who were trying to help the people in those countries. And so we're like, great, we can go see this guy. And And we had to trudge up to Kazakhstan, which was another whole saga. We got there. I went into this appointment. I was just so relieved to be able to talk to someone from my own country. And I'd figured out this was a heart thing. You know, when I'm laying down, I'm fine. When I'm sitting down, I'm not so bad. As soon as I stand up, my heart rate's just through the roof. And so we explained the story to him, and I could just see the veil coming over his eyes. And he just kind of, in the end, was like, look, don't really think there's anything here. I think you're fine. And I did challenge him to take my heart rate when I stood up, and he said, you know, there's nothing we can do really for this. And he didn't actually even say the words anxiety. Wasn't till the next day that I heard from the hosts who were looking after him that he thought I had an anxiety condition.
Yeah.
And I didn't even know what anxiety really was. I wasn't from, you know, we didn't talk about it back then. You know, and I'm like, I'm the world's least anxious woman at that time. I mean, I just worked in a war zone in Yugoslavia, and I just was the opposite of that. So anyway, we came back to Australia. I went to visit other doctors, the same thing.
Before you go on, Marie-Claire, can you just take us through how that landed with you at that time? Like, I mean, not even perhaps being told to your face. I was hoping this story was going to be this amazing doctor from Adelaide came and told you what it was, and then that was the turning point
as well. I was just like, oh my gosh.
But anyway, that's not the way it is.
No, it was. So, I've actually written about this in a. I wrote a chapter on. It was in an academic book on being a lived experience researcher. And I talk about this journey in there, and it was really from being a patient to a researcher journey. But it was the most instrumental, defining kind of moment in my journey to becoming a nurse and then later on doing my PhD. I had never been confronted with a situation where you were given no belief back from someone, where I actually remember saying to my husband, I feel like I've been dragged into a court with the charge of murder and then told I can't give my defence, and they've found me guilty with no discussion.
Guilty of anxiety.
Yeah.
How dare you?
And worse than that, when I reflect on that interaction with that doctor, was he was too embarrassed to say the words anxiety to me.
Yes.
Which tells you a lot about the stigma around mental health, because in my experience as a clinician, people who experience anxiety are quite willing to discuss their anxiety. And you can have anxiety and coexisting illnesses, and that's something else to state, you know, and anxiety is something that you should not be ashamed of. But certainly at that time, there was, you know, stigma around the condition. There still is, and he wasn't willing to actually voice that to me.
And perhaps the guilty charge was of going to see a doctor where there wasn't an observable pathology.
Correct.
How dare you have an invisible complaint?
Yes.
And as a GP, and this came up on a recent episode that we recorded here, was around GP Dr Carmel Reynolds was talking about sometimes the wall that comes up from the practitioner isn't about the patient, it's about not wanting to be vulnerable in coming across something that they don't know.
Yes.
So there's probably a number of layers going on in that onion, but from what you're telling me, I feel devastated on your behalf for what that must have felt like.
Yeah, it was, I mean, just to get to Kazakhstan at that time, it was a different world. It was unbelievably difficult to get around anywhere in the Soviet Union. You were trudging through, you know, feet of snow to get there. And all the time, I'm walking around with heart rates at like 220, you know, it was just exhausting. But I'm also a very stoic person, and I'm also quite stubborn. And certainly if somebody tells me, you know, that experience made me think, I'm just never going to talk to anyone again. My husband, fortunately, is far more rational, and he was like, well, he's just an idiot. Let's go talk to someone back in Adelaide. So we did have the opportunity to fly back here again in the middle of summer. So, you know, weirdly, despite all my capabilities, I had not associated this condition with heat. And for those listening, heat is a big trigger because it opens up your vessels, so your blood pressure is even worse. So we came back to Adelaide. We went and saw a GP, and he was far more brazen. He sat there, and actually talked to my husband rather than me and said, look, you've married a very anxious young woman.
Oh, my goodness.
I think it's best that you bring her home from where you are. And John, to his credit, was like, look, we want a referral to see a cardiologist, and he pushed that through. We went to see the cardiologist. He put a Holter monitor on me. And that's it tracks your heart rate over 24 hours. So that was useful because we got to see that my heart rate was normal at night time, sitting around 50. I was pretty athletic, so, I had a low heart rate. And then during the day, it was almost always tachycardic, so over 100, and it was up to rates of 200. And so the cardiologist was telling me this, and I'm like, oh, finally someone's going to figure out what's wrong with me. And then he just turns around and says exactly the same thing. Look, you've just got an issue with anxiety. You just need to, de-stress your life. And I remember saying to him, if it's anxiety, why does it disappear when I lay down?
Yeah.
And he just looked at me blankly and didn't answer the question. And that was it. That was the last time I ever saw a diagnosis or care for POTS. I figured, again, we're living in kind of pre-internet world. I figured I was never going to find a solution to this. I knew it wasn't killing me at that stage. I knew that I would have periods when it was better. So we went on back to Uzbekistan.
Wow.
I know. And I wasn't very well, and eventually and I also started getting other things, like I got pneumonia, I got multiple gastrointestinal issues, I was losing weight, and we eventually got the opportunity to move to England, and I went there, and of course it's a cold climate. I had a lovely female doctor who, when I tried to give her my kind of history tentatively when I first met her, because I was by this stage actually pregnant soon after we got there, she said, look, people will tell you it's anxiety. She said, but there's so much we don't know about post-viral conditions, and I think you've got one. And that's all it took for me to feel, okay, this is fine. I'm just going to have to learn to live with this. But it was words that can't be underestimated in terms of the impact it had on me, I think. And then I was pregnant. Now, one thing that happens when you're pregnant is you produce a lot more blood flow. You get a lot of pressure inside your abdomen, which holds your blood pressure up. One thing we know about this condition is people lose a lot of blood volume into their lower pelvis when they stand up, more than the average person, a lot more than the average person. And so I was quite actually well during my pregnancies, but then post-pregnancy, things would fall apart a bit. But I managed the condition, and I did that right through till about, 5 years ago before I actually got involved in what I'm getting involved in now. And I can talk a bit more to that, why I did that later if you want, or now.
Yeah, keep going.
What an amazing journey,
Yeah.
though. And I say amazing, not that it's amazing, but just the incredible, I guess, stamina and persistence and willpower that you've shown to get through what you have, given those times as well.
And the medical trauma as well.
Oh.
And I must admit, listening to you tell your story, thinking about how many people would be listening to this probably with tears in their eyes, thinking, I know this feeling, I've done this, I've been here. And whether or not specifically with the symptoms that you mention or their own set, it's a very common theme that I see every day in people who I meet who've got complex pelvic pain and other issues.
Yeah, and I think that's, with the advent of social media and the internet, I wouldn't have much hope for us discovering much about these conditions if it wasn't for actually the internet and social media, because what that has done is given all these, particularly women, but lots of people in the world who were suffering in isolation, who had no recourse to, I thought I was the only person with this, whatever I had.
Absolutely.
And I didn't have a concept of how common it was really until the last 5-6 years when we really kind of opened up the Australian POTS Foundation and started that. So what happened in those intervening years, I went on to have 4 children and multitudes of, in the midst of this, I've got all these things that we'll talk about later that cross over, endometriosis and adenomyosis and, lots of gynecological issues. Had large bleeds with my children and so on. And, every new thing was, we don't know why that happened. We don't know why this happened. Then my children all had lots of, not terrible things. And I want to put that in context. They're all things that were clinically needed treating, but they weren't life-altering. But, they had ureteric reflux, was valvular issues, and so they got lots of nephritis, needed treatment for that. And my daughter was diagnosed with celiac at 18 months. She was quite sick with that.
Wow.
She was born with bilateral club feet. She was treated for that. My eldest daughter had multiple dislocations of her elbows before she was 2. They call them pulled elbows, but hers were so bad that if anyone held her hand, her joints would just dislocate. Every new thing, people would just say, oh, that's a bit unusual. It's just one of those things. And I started thinking, this is just ridiculous.
Yeah.
I don't believe in coincidences in medicine.
Not to that extent.
No.
Yeah. So I started getting frustrated with the process. I had wanted to do nursing when I'd left school, but I was a bit too keen to go travelling, so I hadn't. So after baby number 3, we actually came back to Australia, and baby number 4 was born, and he had a lot of health problems. He was my first boy and was found to have a metabolic disorder that, again, nobody had a name for, but was quite impacting on him. He was born with lots of hernias that needed surgical, resolution. These are all issues that interplay with the connective tissue which holds our body together. He had a bleeding disorder. I have a bleeding disorder. My other daughter had a bleeding disorder. Again, all these issues, I started thinking they can't be not connected. So I decided the best recourse was to go back and go to university. And with 4 children, a 6-month-old baby, I went to study nursing in West Australia.
As you do.
As you do.
Pick up another thing.
I know. And it was a revelation to me. I loved it. I loved achieving. I discovered I was actually a bit of an overachiever, which I hadn't been at school. I was it was all too boring for me. And then we continued to move. We moved over to Victoria. I became an emergency nurse. And that's when I really started to see, oh yeah, these people come into hospital all the time. I still actually, when I started emergency nursing, I had done a bit of research, and by that time I had the name POTS, but it wasn't being used clinically.
And this is how long ago?
So that would have been in the early 2000s. Well, that was probably around 2005 when I was working clinically, and I'd already found, that initial paper on POTS, and there was literature coming out in the late 90s and the early 2000s. So it was kind of in the literature, but certainly clinically and certainly in Australia, people weren't using the name POTS. Probably that changed over the next few years. I saw more and more people coming through and, I've got POTS, and they
would come through and tell you that they've got POTS.
In emergency department, yeah. And this was in Melbourne, and there was a group actually in that time frame that were kind of treating POTS. There was, you may remember Greg the Wiggle, the yellow wiggle.
Mm-hmm. Yes.
Quite famously had to give up his career because of POTS. And he donated to a group in Melbourne that were researching it for a while. So there was an awareness coming through, but in clinically what I saw was, the roll of the eyes, here's another young white female, give her a bag of fluid, send her on her way. And I knew how they were talked about behind the scenes. I knew the disdain for it all. So I didn't even ever discuss with my colleagues my condition. And I was a resuscitation nurse, and I'd be in resus. I'd put the pulse oximeter on every so often because I was feeling breathless. My heart rate would be 180. I was completely unmedicated and working these long shifts, and night shift ended up absolutely killing me because one of the other things that goes with POTS is sleep disorder. So I didn't sleep well anyway, but then I'd have night duty. And then I went into academia, which was a lot easier for me to manage, a lot more sitting.
Could I just ask before you move on to academia, when you were in the emergency department, I've done my share of those shifts as well as a junior doctor, did you have a chance to chat to any of these eye-rolling causing women who were coming through? Because you must have been like, I recognise this, and I don't think you're I don't think you're a troublemaker.
No.
And did you get to share any of those experiences? Maybe not even your own experience, but did you get a chance to have some conversations with those people?
I think with the patients, I always did.
Yeah.
And I always, I still just go back to what that wonderful older GP said to me. And I thought that, that's all I could give them at the time, but was to say, look, we see people with this. What you need to know is there is nothing wrong with your heart. We've done those tests, and that is important to let people know this is actually not a heart condition. It's a nervous system condition. And the heart is affected because of the blood flow. But I would give as much consolation as I could, but that was kind of it. And I knew there was no point really advocating for any more. There wasn't anything to be done. I mean, emergency department isn't the place for people with POTS.
Correct.
And I would stress that, but 100%, I do not blame anybody who goes to the emergency department with it. I mean, you get terrible chest pain when your heart rate's going that fast. You feel like you're going to die. We're always banging on about, act early on these things. And then we get irritated with young women who do that when they've got no explanation for what's going on. And actually all it takes now, I would say is a 10-minute conversation with them to at least start them on a path to how they can actually manage this condition. And that would avoid a lot of these emergency presentations.
Definitely. And with a policy hat on, I can imagine if there are policymakers listening to this to think about what's the cost of not supporting these people with POTS. We live in South Australia. The ramping we know about, the emergency department overcrowding we know about the hospital overcrowding. And you're right, I think if there's more awareness in primary care, and there's some, we'll get to it, but there's some simple investigations that can be done through primary care, and so much treatment can be started, and so much that we can validate people, we can help them understand, and we can send them on their way. And you just think about all the costs that won't be incurred to the health system if we can do that.
Yeah, and I think a point to really raise around that is that we often only know the cost of diseases because they have what we call this international classification, a disease code that goes with them. So anytime somebody goes to hospital primarily for asthma, that asthma diagnosis written in their notes is coded to a code that goes to the health department. The health department and the Treasury look at how much these conditions are costing in terms of presentation, things that had to be done in hospital, and they can quantify it. And then they divvy up the money according to those. POTS hasn't had a ICD code in Australia. There was one created by the World Health Organization, and that was for the version that's coming out next, the ICD-11, but Australia's not adopting that for some years. So we advocated for that ICD code to come in, and it actually comes in on the 1st of July. But suffice to say, this is not only an invisible illness, but the cost of it has been completely invisible. When somebody goes to hospital with a fast heart rate and they've had a faint, that will get coded under other cardiac conditions, who then that is counted almost to how you split up the money. So the money, we've got to stop these cardiac presentations, a lot of which in the younger population are not going to be anything to do with the heart. So that ICD code was really important for us to get in place. But we've done our own research in the Australian POTS Foundation to look at the cost. And in over 600 people that we surveyed, and we use these special tools that are validated to look at the economic survey, 58% of people who get POTS have to give up their current employment. And 8% have a caregiver who has to give up their current employment. Over 50% of them have gone to emergency department prior to diagnosis, on average 5 times, 5 presentations to an emergency department before they ever get a diagnosis. Imagine if that first presentation to the emergency department resulted in somebody actually even handing over a leaflet saying this is what not even diagnosing it, but saying you don't have X, Y, Z. You could have this. You look like you might have this. Take this back to your doctor, your GP, and see if explore this. Imagine if we did that and we just stopped these multiple, and the stress that goes with not knowing when you're going to pass out. Are you safe to drive? Are you safe to attend university or to work? So
I think we can't underestimate the significance of these symptoms that people are experiencing. And I know from my own experience and the people that we've seen, they feel like they're being dramatic. They feel they do feel unseen and unheard, but you can imagine the scariness of having these symptoms of not being able to breathe, having chest pain, all the symptoms that we're told to present to emergency with, but yet then you get there and that this is what you're presented with.
It is life-changing condition. And people that work in the area of POTS almost always have some connection to it. And I've watched the journey of colleagues who have been sympathetic, but they're sympathetic, but that they don't quite understand. And then because this is a relatively common condition, it's not rare. And when it does happen, and I've seen it happen to people, you just watch that veil lift and they're like, in fact, I had a pediatrician said this to me. She got long COVID and ended up enrolled in my study, and she had POTS. And she said to me, she was an older pediatrician. She said, I know this condition. I've treated people with it over the years. She said, I had no idea how debilitating this was. And unfortunately, the condition, from what we see clinically, does not just magically go away. People definitely get better at different stages, but it does tend to be a chronic but fluctuating condition, and it tends to come out during these times of different environmental stresses, and in women that's often around these hormonal changes. So puberty, pregnancy and menopause, as well as when we see a lot of changes.
So Marie-Claire, I think you were going to sort of steer in and talk about some of your research and also your role in setting up the Australian POTS Foundation. But perhaps before we move into that, we're already halfway through our episode. Can you explain, I had a bit of a crack at explaining how I interpret POTS and how I explain it to people that I see as a GP. Can you tell us what POTS is in plain language, and how might it show up for someone who's listening?
Yeah. So as Alicia said, it actually stands for postural orthostatic tachycardia syndrome. And I think even the people that actually, first defined and used that name would probably like to change that name. We all would like to. But it was so they defined a diagnostic criteria back in 1993, which incidentally was the year that I came down with POTS. So it was because those were autonomic neuroscience scientists who looked at it and saw that there was this defining pattern of the way the autonomic nervous system was misbehaving, and so that's why it was named after that. But essentially, in a nutshell, you have in your nervous system, you have a subnervous system that we call the autonomic nervous system, and you can think of that as the automatic nervous system. So it controls sweat function, it controls when your temperature, it controls how your gut moves, it controls when digestive enzymes get tipped into your gut. It controls your blood volume that is kept, so it tells your kidneys how much you wee. And importantly, it controls how your vessels move and contract and dilate or open up. And it does that because we have to respond to environmental changes. We live in a world where temperatures change, we move from laying to standing. And if you think about it, we have no heart at the bottom of our feet. And so to get blood from our feet back up to the top of our body, which, is almost the reverse of what we need it to be, we need a system that can get that blood back up. And the way the body does that is really by a couple of mechanisms. One is by increasing the heart rate, and the other one is by compressing the vessels, and particularly in the legs. But we have these big vessels in our abdomen as well that need to also contract. And what they discovered back in the 80s, actually, it wasn't recent, it was a long time ago that we understood that in some people with these weird, what we call orthostatic tachycardia, so very high heart rates when they stand, even before we defined POTS, scientists discovered that there was this group of people, mostly women, who when you put them on a tilt table, their vessels out in their peripheries didn't contract. So blood just pooled and rushed down both to the lower part of their pelvis but also out into their legs.
And just to define for those who might not know what a tilt table is, that's a medieval torture-looking instrument, like a table that's sort of tipped up on its side.
It is exactly what it is.
I have seen it once or twice in my medical training, and not since, but it's pretty much strap someone to it and tilt them up from the bed.
And what that does, just a random note, a lot of study of the autonomic nervous system came from NASA. It came from the fact that when we put astronauts in space, they weren't in the normal environmental space. They didn't have gravity. And they started to develop all these issues. And you might have seen when the latest astronauts who've been up there for 8 months come home, they put them in a wheelchair. Why did they do that? Well, because they've been in space. They've had no gravitation. Their vessels don't react the way they should. They can't put their blood pressure around their bodies, so they become orthostatically intolerant.
Wow.
And they become orthostatically intolerant because their body is deconditioned to the world's environment. And so initially a lot of thought was, all these young women with these high heart rates, they're just deconditioned, they're lazy, or they've laid in bed too much.
I thought you were going to say they were designed to be in space.
Yeah. Well, it feels like it sometimes.
Yeah.
And so a lot of the original treatment for this condition came from the concept, we just need to exercise these women and they'll get better. What we know now is a lot of these people are actually highly athletic. And in fact, one of the world's greatest ever athletes, Katie Ledecky, has POTS. And go and try
She's a swimmer, Canadian swimmer?
She's an American swimmer. She's the most medalled swimmer of all time. And if you just Google a picture of her now, you will see she's definitely not deconditioned.
Yes.
She does probably have some of that connective tissue into play that we were talking about. So POTS is a condition that seems to affect all the autonomics. In some people, the most dramatic is this blood pressure issue. So the blood doesn't come back to the brain. The brain sends out signals and makes the heart go as fast as it can to try and get the blood back up. But in a lot of people, actually, they also have a lot of the autonomic function. So they get a lot of issues with their gut. And so the movement of the gut from the very top to the bottom is controlled by the autonomics. And it's very intricate, the way it interplays with each other, the way that the actual stomach empties into the small bowel. And that is all dysfunctional. It can be fine sometime, it can be slow the others, it can be fast another time. And so people come with issues like severe constipation, or they might have rapid emptying where they get diarrhea, bursts of diarrhea. Because the stomach empties too quickly into the small bowel, they'll get sudden bloating, they'll get issues with their blood sugar management, they'll become intolerant to certain foods. So these people end up going to the doctor with all these weird symptoms, which usually start with, I just feel exhausted. They might explain. They sometimes express, I'm sensitive to light. Now, the autonomic nervous system controls how your pupils dilate and constrict, and so it can affect the light sensitivity. They often have gut function. They often have all these things. And understandably, GPs don't have much time. They're really there to fix the problem that the person comes in with. And suddenly you've got all these issues. Which one do you tackle first?
That's right.
So POTS is a really inadequate name for a very complex nervous system disorder. And it often comes on after an environmental stressor. And by that we mean something that's happened to the person that triggers it, and the most common is a viral infection. And prior to COVID, that was the Epstein-Barr virus. We haven't seen that in research because people haven't tracked it, but certainly clinically that was the most common virus. And you have to understand, most people go to a GP, they don't get tested for what virus is causing their symptoms. So we know that people might have had a cold, might have had this, but as to what virus it was, we're not sure. When COVID came along, we had this perfect lab situation, a very unfortunate event for the world, but for us, almost a silver lining was that you had a mass population event with mass testing of what that virus was, and we can define the point at which many, many people developed POTS, and that was usually within 2 to 3 weeks of their COVID infection, they were starting to exhibiting these changes in their orthostatic tolerance and so on. And we now know about 3.4% of people who get COVID infection develop a POTS type phenotype.
So can I ask then, how much of long COVID is POTS?
Yeah, good question. I did my PhD on that.
Okay, well, and I saw
that was a great
segue. I saw you recently with the floppy hat on, being awarded your PhD, which was
in exactly this. And it wasn't intended to be. I actually wanted to look at the blood volume control in POTS. So to just quickly give an intro to that, the reason I jumped from not being that interested in entering into the POTS research world to being interested was just prior to COVID, I had a couple of years of the worst POTS I've ever had, out of the blue. I mean, I was fit, I was trail running, I was doing lots of things. I was actually, quite arrogantly thinking to myself, I'm just the fittest I've ever been. And then just literally one day it changed. I got up and I fell down and I was crawling to the bathroom for the next months, really, on and off. And what we discovered through that event, I did end up in hospital, was I actually had significant issues with hanging on to blood volume. So I thought, somebody needs to look at this. I had great doctors at that stage, I must say, and there was a wonderful gastroenterologist who took everything I said as being the truth and really helped me to find out what was on. And we found a solution to my really bad POTS at that time, which was a drug called desmopressin, and I thought, I'll go research that. And then I met a great cardiologist at the same time who had a great interest, and he actually challenged me. He said, no one's helping these people. There's no one in Australia that is advocating for this condition, and I'm one doctor in one clinic and there's a couple of other doctors around Australia. Someone's got to do something. So in 2020, we started setting up the Australian POTS Foundation, and I started my research. I needed some funding, and there's a group called Standing Up to POTS actually in America, and they were putting out a research call. So we had started to see, I was working as a nurse in this cardiology clinic dealing with POTS at the time, and we'd started to see a few people coming back from Europe who had gotten COVID in that first wave and developed very, very severe long COVID, and I mean hospitalised, completely debilitated. And they all had POTS, which wasn't a surprise to us. We're like, of course, this post-viral condition's going to bring out a lot of things. So we thought, well, is this different to the POTS that we know from Epstein-Barr virus or from one of these other glandular fever kind of things? And so I applied and actually got this grant. And what we did was we looked at people with POTS who had never had COVID. And we looked at people with long COVID, and then we got a bunch of controls. So people around the same age with neither POTS nor long COVID. And fortunately, in South Australia, we're quite protected from COVID, so we're able to keep the controls pretty protected from COVID. So we had a really good cohort to study, and we did these awful tests, autonomic tests, where you monitor the blood pressure from every single beat to every single beat. So we had a very special machine to do that. We looked at the responses to certain tests. And what we found at the end of that study, it went on for a few years, in the initial small group that we looked at, there was only about 35 in each group. 85% of the long COVID just looked exactly like POTS. They had a lot of the same background in terms of their other conditions. They were mostly women of childbearing age, and they had the POTS diagnosis. We went on to look at that in a larger cohort of about 200 people, and the figures didn't change much. And since then, we published that in the American Journal of Medicine, and since there have been multiple other studies that have shown the same. About 80% of people with long COVID have an autonomic condition. There are a few different types. POTS is the major one. There are other types of ones, and so if they don't have POTS, they often have this orthostatic hypotension or initial orthostatic hypotension, which are fundamentally treated the same way. You just do things slightly differently. So it is very, very common in long COVID.
Okay, so we're here talking about pelvic pain and endometriosis. And we've probably gone down a bit of a rabbit hole talking about long COVID, but I think that's important because you've just been awarded your PhD in that area.
Well, and also there is a lot of overlap with a lot of things, isn't there?
Yes.
And I think it highlights what we always talk about is that, that we're a whole organism in a whole bigger organism, and, and everything is generally interlinked.
Yes, that's right. Yes, absolutely. What I'm interested in asking you about, Marie-Claire, is the reason why we're talking about this today in our Endo Untangled podcast is because POTS is hugely overrepresented in our patient cohort. And I haven't got the numbers on it, and we probably need to talk about, is there a way that we could actually start 100%. Looking at some of these numbers together?
Let's do that.
And it's something that I didn't expect when I took on the project of running an endo clinic. And as you might know, we were lucky enough to be recipients of a federal government grant to set up a clinic to help women with pelvic pain. But what struck me is that the women that we see and the AFAB folks and some men now are coming in with pelvic pain, but also all of those symptoms that you have mentioned across the last 45 minutes or so, which has caused us to pretty much start screening everybody for POTS as part of what we do. And I haven't looked at the numbers yet, but it's a huge, huge proportion. In fact, I actually started wanting to do the NASA lean test, which hopefully we can talk about in a minute, which is the sort of part of the screening test that we do. I actually wanted to find some other people to do it on just to make sure that they weren't all coming positive, because almost all of the endo patients that we do a test on and come back positive.
Yeah.
So do you have any thoughts on, and this may or may not feel like it's outside your wheelhouse, I guess, why people with pelvic pain and endometriosis also often have POTS?
Yeah, lots of thoughts. What I have to say up front is we don't have lots of research yet, but yes, a lot of thoughts. And I think we talked off air previously about this connective tissue disorder. And the reason I put a lot of that story in about my kids and the different conditions that we'd have is because that interrelates to this. And so what I didn't mention was that both myself and my three daughters have all had issues with gynecological issues, one sort or another, but endometriosis right up there, adenomyosis, pelvic pain. And, there's this old kind of Indian story about, the 7 blind men who are cleaning the elephant, and they're all kind of looking at it. And I know a lot of doctors have heard this story, but this is exactly what this is.
The blind men and the elephant story. Cherie and I presented this in South Australian Parliament.
So the blind men and the elephant, if you haven't heard of it, the blind men are all cleaning the elephant, and each one has one part of the elephant's body, and of course their perception of what this elephant was related to what part of the body they're cleaning. And if it's the trunk, it's obviously one thing, and if it's the tail, it's another. And this is exactly where I think we sit with a lot of these conditions. We have a lot of people come into our clinic and say, oh, my endo is terrible. And, when my endo flares, and when you pull apart, what does your endo flaring mean? Yes, it may mean pain. And for some people that's debilitating endo pain, and it's often, related to their cycle. But a lot of the time it's my fatigue, it's my brain fog, it's my dizziness.
And it's not always articulated when someone comes in, but what I often see is, and my constipation or fecal loading, and that doesn't always come in the way that people think it might look like, but it's often there and probably related as well.
Yes, and you can lay the blame actually right back at researchers.
Let's blame somebody
and
today.
I will take that blame as well. A lot of research, what we call observation.
Let's blame you.
Yeah.
Someone needs to be blamed.
Academia.
Yeah, that's right.
No.
So a lot of research is actually done in what we call observational, and they're those big studies that go, all these people with this X, Y, Z condition or X condition, what other conditions are related? And we've done that with endometriosis. If you've got endometriosis, what are your symptoms? And so we get all the symptoms and we say, oh, people with endometriosis get a lot of constipation. And so then the assumption often then comes out both in the public's mind and sometimes in clinicians' minds that endometriosis is causing constipation, but actually all it is possibly is an association, meaning that the same people that get that symptom are going to get endometriosis. And I think that's what we're talking about here with POTS. Why is POTS and endometriosis so closely related? We definitely know it is. So we've just done a study that we published which showed in I was trying to remember, the European Cardiovascular Journal of Nursing, and it's open access so anyone can go have a look at it. But we looked at the sex differences in people with POTS in Australia. We found in that cohort, so that was 500 people, that the clinical diagnosis of endometriosis, so not people saying, I think I've got it, but people who had it confirmed, and Alicia, you'll probably have better stats on how underdiagnosed this condition is, but a lot of young women particularly would never have had a study that would allow them to have an actual diagnosis. So, but the clinical diagnosis was 20% of our cohort. Now, just on symptoms, we think that's at least double that.
So 20% of your cohort of people with POTS, who I guess are women, 20% of them have had confirmed endometriosis.
Correct.
So,
Correct.
And you're right, massively underdiagnosed. So,
and these are young women, so they're less likely to have had a lap or anything else. And then when we looked at the amount of menorrhagia, so heavy bleeding diagnosis in them, it was more like 50%.
Yeah.
So, this, and then I'm actually just doing a new study. So one thing to know about POTS is who is likely to get it. Number one, it's women. But men do get it, and I need to really express that. About 10% are men, and you can get
10% of the POTS population are men.
And one of the other causes of POTS or triggers for POTS can be concussion, and that's more common in the male population. And they do present quite differently, I must say that. And we think that is a kind of partly to do with the brain inflammation that can happen from concussion and the autonomic control. But let's say we take the 90% who are female. The most common associated condition is what we call the hypermobility spectrum disorders. And they're a group of connective tissue disorders where the connective tissue, the collagen, the proteins that make up the connective tissue can be altered in one way or another, whether we think it's genetic, but there's probably also some environmental factors there. So we know that inflammation can essentially meat tenderize the collagen, and that can cause, so people with lots of inflammatory conditions can end up with this. We know that we have hormones that actually relax the connective tissue in women, preparing them for pregnancy. So they're more prone to injury around the time of pregnancy. So people with connective tissue disorders typically have this. When they were young, they were hypermobile. They may not be now, but by hypermobile, we don't mean flexible. We mean the joints are unstable. So they might have a history of being a bit double jointed. They might have been able to do things like the splits. They might have been able to have these elbows that hyperextend.
They've got party tricks often.
They do.
We hadn't realised how many rabbit holes we wanted to go down, so I've decided to split this podcast into two parts. So we will leave the podcast here for today, but stay tuned for part 2 of our POTS episode, which will be dropped shortly.